Restart. Wonderful, thank you. So we have a pretty big agenda today. So we'll first have a look at our World Malaria toolkit that has been lovingly prepared by Priyanka. And then we'll follow up with two presentations, both of which have to do with things to take into account as we plan for GC8 funding requests. First, we'll hear from colleagues from MSF, so broad reflections on how to best finance health interventions. And this is a bit of a trailer for longer discussions that we'll hold next week and the week after that with regional partners on health financing. And we'll also share an overview of some briefs and tools that we are releasing to better understand the US MoUs and how they will impact GC8 planning and implementation. Without further ado, I'm going to give the floor to Priyanka to talk about World Malaria Day.
Thank you so much. So the World Malaria Day is on the 25th of April. That's the Saturday. The theme for this year is driven to end malaria. Now we can, now we must. But if we want to end malaria within our lifetime, we need sustainable financing, especially sustainable financing for the most well-proven interventions that we have against the fight against malaria. So for the World Malaria Toolkit that we have for you today, it basically covers a large ambit of topics, and we want to focus in on the fact that two interventions that receive the highest dollar cut in GC7 reprioritization at the country level were the insecticide-treated nets and also the seasonal malaria chemo prevention. Both of these are fairly cost-effective tools and have a large reach. And what has happened in GC7 reprioritization exercises should not become the roadmap and should not be replicated in the GC8 funding requests that are being designed and planned at country level currently. So in the toolkit, you'll find what are the interventions that are at risk, what are the backing evidence and data points that you can use to be able to meaningfully engage with the CCMs and advocate to ensure that these interventions are not cut from the GC8 funding requests. And also you will find a social media toolkit to support your online action and advocacy around these key topics. What you will also find within the toolkit are sections on how climate change is fueling malaria. That is not news for any of us, but it is also integral to understand that investment in resilient health systems is investment in combating malaria, fighting malaria. So we do not want to see cuts in resilient health systems as well. And those priorities also need to be well preserved within GC8. We also want to bring your attention to a set of documentaries and resources that have been published by Impact Centrafrique around the hashtag Protect the Cure. This basically talks about the growing resistance around the first line ART and what we can do to be able to protect the cure, because as we know, we will not have new drugs available at least until 2027. So it is imperative that we use the tools, including the drugs that we have, to the best of our capacities. And what are the tools and what are the strategies that are needed at the country level to be able to ensure that is well covered by this particular website that has been developed by the Temple University and Impact Centrafrique called Protect the Cure. Direct links for that, as well as all the other partner resources, including the wonderful toolkits that have been put out by the Global Fund, by CS4NE, by GFAN Africa, and by Zero Malaria and Target Malaria are also available on our webpage. In case you are listening into this call and feel that we've missed out a toolkit or we've missed out a particular area of focus, please do let us know. It's a living toolkit. We are open to amending it. just one quick highlight that because the World Malaria Day is on Saturday, we are asking partners to start posting from tomorrow onwards and continue posting all through the next week. And that's all from us. Thank you so much.
Thank you very much, Priyanka. And I want to give a chance to any partners on the call who also have World Malaria Day related news or updates to share to raise their hands and take the floor, or post it in the chat if you're feeling shy. Once, twice, thrice. All right, then we'll be moving on. And just before I give the floor to colleagues at MSF, I want to situate a little bit the two conversations that the two other conversations that we had planned for this call. So we're going to have two discussions. Both of them have the same objective, which is to stress that the Global Fund does not exist in a vacuum, which I know a lot of you are aware of, and we want to try to give you tools and framework to sort of think along these lines. So as we planned for GC8 and we felt reduced budget, not results budgets, apologies for the typo, we have to take a number of decisions as we design the grants. What stays in the grant? What do we add to the grant because other partners have stopped funding specific interventions? And I'm thinking in particular to the US, and we'll hear more about that later. And what do we take out of the grants to hopefully fund somewhere else? And so these decisions will have to be informed by an understanding of where is their funding, and again, an understanding in particular of government budgets and the current state of government finance, and the current state of other other funders, in particular bilateral funders, in particular the US, is particularly important, and what funding channels would minimize risk. Because as our colleagues from MSF will discuss, it's not just about where the money is, but there are certain channels to fund certain interventions that are more or less suitable. And so that's really what we want you to think about in the next through the next two presentations. With this, I'm gonna stop sharing and give the floor to our colleagues at MSF. I'm not sure if it's Tess or Nuria first.
It is me, but I have requested whether I can share. Okay.
You should be fine now.
Yeah, I'm fine now. Hello, everyone. So I'm Nuria Brixie. I am not technically MSF, but I was MSF at the beginning of my life. As you know, once MSF, always MSF. So I'm very happy to be speaking under the banner of MSF. I'm actually an academic at the London School of Hygiene and Tropical Medicine. And I also work with the World Bank and the GFF, and I have been working on issues relating to health financing for the past 20 plus years. I think this is an incredibly important issue, understanding what health financing is and what it can or cannot do for us. And I'm really happy to be talking to you about it today. I'll talk for about 15, 17 minutes. And then Tess, I will hand over to you. So the reason why we say that health financing is really important, we know, as has already been mentioned, that there is an expected, or there has already been a very large decrease in the amount of development assistance that is going to health. We think that it's going to be about 20% by 2026, but expectations are that the numbers are going to increase. I'm going to slow down how fast I am talking. Apologies for this. And these decreases in international aid are leading to real-life consequences. A Lancet projection has shown that we expect an additional 9.4 million deaths as a result of the US aid cuts alone by 2030. So this is really an important topic to put on the agenda. And it's particularly important because many donors, including the Global Fund, are now asking countries to co-finance. And that means they're asking countries to come up with domestic resources to compensate for the reduction in aid. So what we are going to be talking about today is what is domestic resource mobilization, why it's not as easy as saying to countries you need to raise additional resources, and what it is that you as civil society can do to engage in a meaningful way in these debates. As Quentin has said, this is a taster session. I'm going to be covering quite a lot of ground and not necessarily going to a lot of detail, but I think that an upcoming session will give us more space to really explore each of the topics that I'm covering today. First things first, when we talk about health financing, we're talking about three things, three core functions. Often, people equate health financing with just the first function of financing, which is revenue raising. And undoubtedly, it's very important, but it isn't the only aspect of health financing that we health financing experts engage with and that we think that you as civil society should engage with. But so the first function of financing is revenue raising. This is just about how we can mobilize additional resources in the overall budget and for health in particular. It's not rocket science. There's not a zillion different ways of raising additional resources. We're really talking about taxes or insurance contributions. In low and middle income countries, we're also talking about donor grants. The reality is that, the fact is that when we talk about domestic resource mobilization, we're really just talking about taxation and insurance contribution. We're not talking about aid. And very importantly, when we talk about domestic resource mobilization, we're also not talking about user fees or out-of-pocket payments. User fees and out-of-pocket payments are a tax on the sick. They are not what is considered by health financing experts as desirable ways of raising domestic resources. So DRM is taxation and public revenues only. That's the first function of financing. The second function of financing is once you've raised these resources through taxation or through insurance contributions, you need to bring them together onto a pot. By bringing these resources that you have raised together onto a pot, and this is called pooling, you are ensuring that the risks and the resources of the different people that have contributed are brought together. And this is an essential part of achieving universal health coverage, because it is through this pooling that we are ensuring that there is cross-subsidization between the healthy and the sick, and between the rich and the poor. If we don't bring the resources together, if we don't pool them together, there will not be cross-subsidization, and we will not progress towards improving financial protection of the population. The third function of financing is purchasing. So once we've pulled these resources together, we need to use them and buy services. So when we look at purchasing, we answer questions such as, what are the services that we should be purchasing? Are we just purchasing primary healthcare? Are we also purchasing secondary healthcare, for example? And these are all the questions pertaining to the benefit package. How do we define the benefit package that will be purchased by the pooling agency? We also address questions of how we're going to be purchasing those services, what type of provider payment mechanism we will be using. Are we contracting facilities in any way? And we also answering questions of who we are purchasing these services from. And by that, I mean, are we purchasing only from the public sector, for example, and at what level of the public sector? Or are we also purchasing services from the private sector? So financing is three key functions: revenue raising, pooling, and purchasing. They are norms that have been established thanks to decades worth of evidence that help us understand how we can progress towards universal health coverage, which ultimately is everybody's goal, and everyone has signed up to UHC as a goal, including all low and middle income countries. The first norm in relation to revenue raising is that we know that to progress towards universal health coverage, we need public financing. It is essential. And that we will not progress towards universal health coverage if we rely mainly on private financing. And private financing is out of pocket, it's private health insurance, it's community-based health insurance. It's all those financing mechanisms that are administered or managed by the private sector rather than the public sector. So that's one lesson that we have learned. And that's why we put so much emphasis and so much pressure on government to increase how much they allocate to health, because we know that it is only through public financing that we can progress towards UHC. In relation to pooling, what we have learned is that the bigger the pool, the better the cross-subsidization. What this means is that we need to move away from systems that have lots of different pools, that have fragmentation in their system. And we see that in a lot of low and middle income countries where governments, for example, will set up social health insurance just for the formal sector, which often represents a very small portion of the population. And this very small population will be pooling its resources together, and they will do subsidization between themselves, whilst the rest of the population, the informal sector and the poor, are left without support. And finally, on the purchasing side, what we have understood through evidence is that we need to move towards spending resources better. We know that a large proportion of resources are wasted for a number of reasons, and we need to step away from that and try to become more efficient and bring greater value for money in the way that we purchase services, move towards more strategic purchasing. One thing to note here is that greater value for money or greater efficiency does not mean cost cutting. When we talk about value for money, we're talking about an equation that brings together the outcome, for example, quality of care, and the cost. If you reduce the cost and you reduce the quality of care, this is not efficiency. This is just cost cutting. So it's a very important point to bear in mind when you engage in these discussions. There's plenty of benchmarks that exist based on evidence that shows what it is that we should be asking for. We could, for example, ask for a minimum of $60 to $80 per person per year. This is what international evidence says is the bare minimum to be able to progress towards universal health coverage. The majority of low and middle income countries are far from this. We've all heard about the Abuja targets, which says that 15% of national budgets need to be allocated to health. Most of our countries are far from this, and all projections show that before we achieve this target, we'll be well into the 2100. There's other targets out there that we need 5% of GDP, for example, to be allocated to health to be able to progress towards universal health coverage. We can talk about these targets and their relative values, but they exist, they are recognized, and you may decide to use them in your advocacy. There's other important targets in relation to out-of-pocket and catastrophic expenditure, which countries are, there's no country that achieves them, but these are important targets that we can talk about. And I just want to hone in for a second on this concept of progressive universalism that has grown in the international literature that says that if we want to progress towards universal health coverage, we need to start with the worst off. We cannot start, for example, just with the formal sector that tends to be the better off part of the population. In whatever we do, we need to start with the services that the worst off are using and making sure that they don't face financial hardship as a result of seeking services. I just wanted to talk a bit more about out-of-pocket payments, but I realized that time is running really fast. So I am going to spend the next few minutes on what it is that realistically countries can do to replace donor financing. This is something that we call fiscal space analysis, but without going into too much of the technical details, just want to tell you that there are a few options for countries to raise domestic resources. The first option is economic growth. But let's put that aside. It's the best possible answer to having additional resources. But leaving that aside for a minute, the first option is general taxation. I've told you that this is a very important pillar in progressing towards increased domestic resources. And there is no doubt that it is the most sustainable long-term route. The problem is that, one, we are health people. So it's very difficult for health people to go to ministries of finance and start telling them what they should do in relation to taxation. I've been in these conversations many times, and Ministry of Finance will say, well, who are you to tell me what to tax and not to tax? So it doesn't tend to be a good starter of a conversation. So the health community has then honed in on what we call health taxes, which we used to call sin taxes. These are taxes on products that are harmful to health. So for example, tobacco, alcohol, sugar-sweetened beverages. And in that field, the health sector has it's more politically acceptable for health to go to ministries of finance and talk about those, because we are the ones bearing the brunt of the consequences of people drinking or smoking or drinking sugar-sweetened beverages. The problem with those taxes is that the revenue that they can raise is rather limited. Systematic reviews have shown that we can raise up to 0.5% of GDP with those taxes. So they're a good conversation opener, but they're not going to be your primary solution. Then a lot of countries are now talking about social health insurance, the fact that they want to put in place a mechanism that is contributory, and it tends to be for the formal sector. There's a lot of problems with those, but it could be part of a solution. But it's important to realize that firstly, the informal sector is excluded, and secondly, that the level of coverage that is achieved in most low and middle income countries is extremely limited. Then, of course, there is the potential to reprioritize the budget. So making sure that more resources within the budget are allocated to health. And I've shown the different benchmarks that we can use to try and have conversations with the ministries of finance for more of the budget resources going to health. Then there is debt. So we could have conversations with the government around debt relief. And there's a lot of talk at the moment around debt to health swaps. They can unlock fiscal space, undoubtedly, but the negotiations tend to be very complicated. They're not available to all the countries, and there is a cost associated with these debt swaps. And finally, there is the let's spend our resources better. If we can't increase the overall pot, let's make sure that we increase the fiscal space through spending resources better. And WHO report said that there was up to 40% of resources currently in the health systems that were wasted. There is no doubt that we can all spend the resources better, and there are other areas that we can look into, but let's be clear that these sources of inefficiencies are rooted in political settlements that are very hard to fight against. I'm not saying we shouldn't, but they're hard to fight against. So it's a very political debate, and it's also a very technical one. Nevertheless, these are the areas that we can realistically talk about when we talk about additional domestic resources for health. What is clear also is that none of these are simple, and all of them are potential option, and I would recommend that we engage with all of them, but we need to realize that these won't happen quickly, that they're not necessarily very easy, and there are risks associated with all of them. So this brings me then to my last slide before Tess, I move on to you. There is a risk in our conversations with governments in premature transition. It's very important to not set over-optimistic domestic resource mobilization targets with countries. It's very important when we engage on transition plans that we try to be realistic about what can happen, what health tax can be implemented, how quickly can we move from identifying an inefficiency to actually improving the efficiency of the way in which drugs are procured, for example. So there's many areas in here, I hope, avenues that we can look into in more detail as we do advocacy and make sure that we set out realistic domestic resources targets for the governments. On that note, Tess, I hand over to you.
Great. Thank you so much, Nuria. For those who don't know me, I work for MSF and I link up all of MSF with the Global Fund. And really super grateful to Nuria as the expert on health financing here. As she said, this is very much an intro, and I'll put in the chat a link to a survey with just a few questions to ask you what would be useful for you in terms of further explanation into health financing, what your priorities are, what your concerns are, gaps in knowledge, what you would find useful, that then we can take advantage of Nuria and her expertise to look at further. A lot of what's on this slide here in terms of civil society, I know that you know, we're all working in on the same arena in terms of this, and it's very much in terms of making sure that civil society brings home the reality of what people affected by the 3 diseases is, and making sure that the money is relevant according to those needs. So it's the role in terms of civil society, as I know you all know, but very much about bringing the reality check, giving those key insights into what the gaps are in terms of the response, and really making sure, as I say, that the people at the heart of the 3 diseases are at the center in terms of where spending is allocated and what the response should be in terms of when these decisions are being made in co-financing or domestic resource mobilization, where those should take place. And also, crucially here, it's about accountability, right? To make sure that we hold accountable in terms of the spending according to the needs that we see them for civil society. Next slide, please, Nadia. Okay, so the key points here, and Nuria has excellently explained them as well in terms of the out-of-pocket payments, for example, and in terms of the pace, right, and the scale. So we all know in the allocation letters that there's a percentage according to the context of co-financing requirement for the Global Fund. It's really keeping that in check in terms of what we see or what you see in terms of civil society, what the needs are, what the gaps are, the key insights. Does it make sense? Is it realistic? Speaking as MSF and working in a lot of conflict areas and emergency areas, these co-financing agreements, they're not necessarily realistic. They don't really make sense for all of the different priorities that are taking place for these contexts. Like I'm thinking of DRC or Sudan, South Sudan. We know that they have to be in there. We know that the Global Fund is under a lot of pressure right now. But we also know that the reality is, and the data and the insight that we have is what we can provide to say, look, in terms of managing expectations, that won't necessarily work. And crucially, to Nuria's point around where the emphasis is or where people are looking to fill the gap in terms of financing, out-of-pocket payments must not be one of them. And again, around it's not to Quentin's point in the introduction. Yes, the Global Fund, but this is the bigger picture also. So it's also looking at what the national budget cycle is looking like keeping an eye on what's happening in terms of the Ministry of Finance and beyond the Global Fund in spending as well. Next and last slide. Okay, so I'm not going into much detail here because I'm aware of time, and I'm also aware that preaching to the converted in terms of civil society role and what we all do, but it's just to make sure that it's all outlined here so you have it accessible to you. I would just mention on this slide, and to Noria's point as well, the concept of progressive universalism, really useful in terms of making sure that key populations are at the center of the response and prioritized in terms of the response. And then also to some of the key concepts flying around for the Global Fund and Grant Cycle 8 around integration, for example. Again, making sure that in these processes and these policies that are being presented to us, that we are making sure that it is the people that are actually at the heart of the response and they're not being cut or sidelined, which again, speaking as MSF for displaced populations, for people in remote areas and so forth, we know that they're not at the heart necessarily of the MOH. And it is our job to make sure we highlight those needs and that those funds go towards meeting the needs of those people and they're kept in that assessment of how to use funds and where to spend it. I'm going to end there. I'm going to just put in the chat a link to the survey. This is an opportunity to take advantage of a real expert in terms of health financing, as I say, but also to really get to grips with what's being proposed in these allocation letters when it comes to the co-financing requirement and the DRM and so forth, and see what that means for your context. And we're really keen to hear from you to try and make sure that we can make use of understanding this and how to respond. Thank you.
Thanks a lot, Noria. Thanks a lot, Tess. We do have a bit of time for a bit of a Q&A. If anyone has any question, you're welcome to use the chat, but you're also welcome to raise your hand. See lots of claps. Louis, go ahead.
Thank you for the presentation. That was really helpful. The big challenge, I think, with domestic financing is each organization asks for domestic financing for the area that they work in. So you need to provide domestic financing in relation to the Global Fund, but you also need to find in relation to Gavi or the Pandemic Fund, et cetera, et cetera. So is there a way of, when looking at domestic financing and looking at the amount of money that's required for all these different things, for that to be put together in a more holistic way as you talk about raising funds through taxes and fiscal space? Thanks.
Thanks a lot, Louis. And Solange, because I know you have to leave soon. Go ahead.
Yes, here I am. Hi, everyone. Good to see you. And thanks, Noria and Tess. I just wanted to maybe ask you to expand a bit on debt to health swaps. I think when we are in this space, we often we end up in the fiscal, trying to find fiscal space conversation, where I don't think the HIV community in particular, obviously this is HIV, TB, and malaria, but the wider health community is as versed in those fiscal conversations and the technicalities of, let's say, what happens in a financing for development conference. And so we end up regurgitating some things that we hear, like these debt swaps and debt for health swaps. But if you can just expand a little bit on it, one of the things I have had the opportunity to kind of explore, but would like your input, is around the sort of redirecting and restructuring of money rather than actually creating fiscal space. So in terms of when civil society is advocating, you can be seduced into thinking that there is now more money, but in fact it is money that is relabeled or redirected. And I just want you to maybe clarify that a little bit for us. And also, what happens to what is your advice as civil society when you hit another roadblock around countries that don't have the taxation space? You can't tax Malawi to death, and you can't tax Zimbabwe to find the fiscal space. And so therefore, what are the actual options, because I really do think that civil society should be bringing solutions, not just clamoring. So I would love to hear your perspectives on that. Thanks.
Thanks a lot, Solange. And we'll take one last question from Deepak. Deepak, go ahead.
I thank you very much for the interesting conversation here. And my question is that it is also related to our earlier questions that we learned. I'm just curious about all the global south and third world. They are already in debt. In that case, each and every program see their program as the first priority. In that case, how government, poor countries can accommodate all these priorities? Can we have a good consolidated priorities on behalf of civil society so that we can support better to the government despite all these challenges? Thank you.
Thank you so much. And any additional questions, we'll have to go in the chat. Noyates, this is quite wide, but you have 4 minutes.
Let me solve. Okay, so these are really, really good questions, and they go to the core of all of the issues that we face in countries. So this issue of fragmentation between the different donor and every donor coming in with its own priority is. And asking for fiscal space for its own priority, for example, or a tax for its own priority is bad. And I'm taking shortcuts because I don't have much time. Really, what we want to do at country level, or what I do, for example, at country level, is engage at the level of the benefit package first. What should we put in the benefit package? What part of non-communicable diseases do we put in the very essential benefit package that the country is doing? And for example, in Sierra Leone, we are engaged in conversation with the Global Fund about how we're going to be integrated some of the things that they do within the national benefit package. That's on the one hand. But this benefit package will grow or not based on the available resources on the other hand. So my recommendation to you, civil society, talking to donors, is align if you can. If there is a national policy process that makes sense, align. But yet be aware that there may be population groups, specific diseases that the government doesn't want to align with. In this case, however much argumentation you will have with the government for domestic resources for your particular aspect, it's not going to happen. So just become aware of that. What can you integrate to the national benefit package, and however much advocacy you will do, will never be integrated in the benefit package. But really, my recommendation to you and to the donors is talk to each other and talk to the government. They're the ones who ultimately are going to be writing the national health financing strategy. Debt to health is a repackaging. So you have debt relief, which is great. So it's a cancellation of the debt. That's not what debt swaps are. Debt for health swaps are, there's lots of different debts out there. We're going to consolidate all the debts and come up with an interest rate that is more advantageous as a result. And the money that will be reallocated to health is the money that we are going to be saving by having a more advantageous interest rate. So if in the past you paid 5%, and as a result of this reconsolidation of the debt, you're paying 4%, that 1% difference is what is going to be, under conditions, reallocated to health. So it's an important thing to bear in mind. And there's a lot of discussions about whether this complex financial instrument is worth it, considering the cost associated with setting it up. And different countries have different answers to this. What is the solution for countries that don't have the taxation space? I think I would challenge that to some extent. A lot of countries don't have the taxation space at the moment because of the way in which they look at their public revenue. We increasingly have heard, or for many years we have heard, the only solution in countries that don't have a big formal sector is VAT, value-added tax, because it's easier. But VAT tends to be really regressive. i.e. it taxes the poor first because it's on things, bread and even I don't know, butter, whatever. So VAT is not the only solution, but in many countries, for example, Sierra Leone, again, where I work, there's a lot of national resources, wealth that is for historical reasons to do not necessarily with very transparent processes are taxed very, very little. National resources that could be reused, look at the case of Botswana, for the population are not taxed properly. So I think that for every country, there should be a look at the way in which tax is organized and public revenue is organized. But there are countries that are just dirt poor and can't do it. In those countries, we shouldn't be talking about transition yet, because to be able to build the economy of those countries is going to take decades. That's it. Sorry. Tess, did you want to comment on anything?
Don't worry, I'll leave it. But all I would just say is, as I said, we will have further sessions to go more in depth, and your responses to the survey will be super useful to get clarification on what to use and what's relevant for you to use for your advocacy. Thank you.
Thanks a lot, everyone. And sorry we had to cut the Q&A slightly short, but again, this is just a trailer for a longer call that we'll be hosting next week with our regional partners, GFAN Africa and GFAN AP. So we'll share the details for all of those on the GFAN listserv as soon as links are ready. And I'm going to give the floor to Chase and share my screen. Chase, go ahead.
Thanks, Quentin. Hi, everyone. So I'll just wait for the slide to come up.
Sorry, give me just a sec. There it is.
Okay, great. Yeah, so I'm going to speak briefly about the US bilateral MOUs for health and the Global Fund's Grant Cycle 8. And just kind of as an intro, because the MOUs involve such large sums of money and outline massive changes that bring with it massive risk. We've paid a lot of attention to understanding the MOUs and kind of opportunities to learn more, to engage, to influence. And at GFAN, we've been following the evolution of that because of its immediate impact for GC8 planning and also for implementation of those grants between 2027 and 2029. So the next few slides, I just highlight some of the key takeaways and points for consideration from a perspective on how they are impacting GC8 planning or should be impacting GC8 planning and how they are likely to impact GC8 implementation. And then we'll close by highlighting just some short complementary documents that we've developed for country level advocates to make sure that they are able to better integrate the new developments and bilateral aid into their engagement in Grant Cycle 8. So just a quick overview of the US bilateral MOUs. This is repetitive for many of you, but 30 MOUs have been signed and only 9 have been public. These numbers may have changed in the past few days, but that's the general overview. The MOUs have a consistent overall structure, but within them, there are important differences from country to country in their substance. In particular, the funding levels compared to previous baseline funding levels, as well as the rate of the decrease in support over the period. So the MOUs are a blueprint of proposed US bilateral funding from 2026 to 2030, but also a blueprint for proposed government domestic funding for health over that same period. So those 2 points are important to keep in mind. The baseline 2026 funding is itself a significant decrease from the historical levels of US funding, levels that were pretty consistent, even if they had plateaued over the past 5 to 10 years. And these MOUs propose or lay out plans to decrease US bilateral aid annually for health across all the countries. And also all the MOUs make that decreasing aid conditional upon yearly increases in domestic health spending, which means they're going to decrease in any case, is what they're saying. But if the countries don't increase their domestic resource mobilization, then the US will cut even further. Of course, a key point to emphasize is that these are high level in a more detailed budget or more detailed framework of the budget and operational plans is supposed to come within 30 days of completion of the MOUs through implementation plans. But as of yet, there's limited visibility that any implementation plan has been fully completed, and no implementation plan has been publicly accessible. Next slide, please. Okay, so just to highlight how this is a major change in the HTM architectures. Across the three diseases, but also for health systems. The point of the lower baseline of funding overall is very important to emphasize, especially when you add to that the lower allocations for GC8 from the Global Fund. But in particular, the MOUs contain within them a major risk of funding cuts if DRM fall short of their targets. So you would have both the shortage in projected domestic resources added on to further cuts by the US in US bilateral aid. So that's a big risk that hasn't been present historically. And I think it's really important. It can get lost just because the numbers are so important. But there are major changes and major risk in proposed reform of norms, possibility of major changes in who leads funding on what intervention areas, major changes to operations, procurement, something that's come up and been flagged as a major risk for US bilateral programs or any of the intervention areas supported by procurement with that money, and major proposed changes to the governance. So those are really important to emphasize, and they can get lost in just emphasizing the drastic changes to the budget numbers. Next slide. Okay, so implications for grant cycle 8. There are kind of two dimensions to emphasize here. There's the implication for the immediate process of planning with most countries in the middle of developing their funding request, targeting the submission in June for funding window 1 and in July for funding window 2. We expect most countries to be submitting their funding requests in those windows. And while it's not unprecedented for the planning of US bilateral aid and Global Fund planning to be overlapping to some extent, the current conditions are a huge change. Historically, there's been a high level of coordination on planning, mechanisms in place for that planning, teams in place that understood how the Global Fund and US bilateral support have complemented each other. And there's also just been underlying visibility and stability that has facilitated better coordination and easier planning. So for grant cycle 8, the CCMs must prepare for funding requests with less complementary funding, less transparency, and more uncertainty. And that's introducing, I think, a new degree of risk analysis that needs to be taken into account by CCMs. So also for from the perspective of civil society and communities, one of the big points of emphasis here is just the drastic change in transparency and visibility. And that, of course, has a huge impact on the immediate term for evaluating risk and responding with advocacy priorities, but also over the longer term for ensuring accountability. And to emphasize that in particular, the current lack of visibility and limited data on plans to fund key populations, at-risk communities, and community systems through U.S. bilateral support. That lack of visibility is a major concern and a major challenge for civil society and communities. The MOU framework does outline a large increase in the role and responsibility of governments. And in turn, particularly because of the emphasis on annual increases in spending, it introduces new importance of engagement with Parliament and with ministries of finance. And it also is increasing the power of the Ministry of Health and Disease Programs. So this is something where for certain objectives, it could introduce a new need for broader coalitions of health-focused community and civil society actors to push forward engagement. And so that's something new that may be emerging just because these MOUs aren't structured in the same way around disease program funding channels as they have been in the past. So these tools, so at GFAN, we've developed 3 tools. The first is a primer on understanding the implications of MOUs for Grant Cycle 8. This is kind of a document that situates some of the dynamics that I highlighted in the earlier slides, but also focuses on what's in the MOUs and what's not in the MOUs at a sort of larger level. And then to complement that, we developed a guide to reading the MOUs. This kind of walks you through what's in it, what's not in it, and where to find various points that you can get information on. And finally, a template for advocates to extract and interpret key MOU information. Right now, that's limited to MOU information. If eventually implementation plans are public, then we might be able to add on to that, and it might be more useful. But those 3 documents are meant to provide country-level advocates some sort of orientation and framework for their engagement and building on the link between the MOUs and Grant Cycle 8 planning. As well as those tools, there are lots of other resources from partners and allies. There are the weekly calls hosted by Change on Thursdays, weekly or bi-weekly now. The weekly calls organized by Partners in Health. David's on the call, and he'll be moderating the call at the top of the hour. There are analyses developed by Chai and Partners in Health that we've linked to in our primer. There are the blog post by Emily Bass, and also there's a few sample letters that may be emerging. One from Kenya that is a very interesting blueprint for engaging ministries of health on a broad range of civil society concerns and issues that are arising from this big transformation in the architecture. And finally, in the primer, we do highlight some possible ask by or to actors. So 2 actors from civil society and communities, and potential ask for civil society and communities to push those actors to take forward towards the U.S. government representatives at the country level. So that you can dig into in looking at the primer. And just very quickly, I wanted to ask if David wanted to just briefly intervene and kind of share what the weekly Wednesday calls are and how to connect.
Yeah, sure. Thanks. Great call. This has been a really interesting presentation. Super useful. So the Partners in Health information sharing call we hold every Wednesday, and the next one will be in just a few minutes. And if you're interested in attending, I put my email in the chat there. Just shoot me an email, send me an email, and I'll send you the calendar invitation. It's a Teams invitation, right? So therefore, you receive a calendar invite. But I can do that really quickly if you're interested in attending. But it's meant to be an informal sharing of civil society actors in this space, where we can share intelligence about MOU negotiation or implementation, and share, emerging crises and what to do about them in relation to this process. Thank you.
Thanks a lot, Chase. Thanks a lot, David. I do want to open the floor for any questions related to the MOUs, but we have time for probably one question, up to two, because we do have to leave at the hour. I am not seeing any hands up. Once, twice. All right. So I hope that many of you will be joining the call organized by PIH on the hour. Again, David has put his email for you to receive an invitation. So thanks again to all of our presenters. We'll be closing the call, but before that, we do have a final request, which is do tell us if you intend on joining the IAS or joining the WHA. There'll be team members in both places, and we want to make sure that people are up to date on events we'll be organizing in both spaces, and can pass out so that we can get in touch and make sure that we are all in the loop. So do take a second to flash either codes and tell us whether you're attending either events, and we'll be in touch soon. And with this, I want to thank everyone for joining. Oh, sorry. Valentine, yes, please go ahead. You have a minute. Oh, sorry. Sorry, I misread the Valentine's message. So microphone problem. I have any news on the UNHLM on HIV. So there are some news on the UNHLM on HIV, non-public, I think. They've entered the silence period, and when we last heard, there was essentially a fight regarding the date. So one of the currently suggested date are in June. A number of countries seem to be pushing for delaying the HLM until December. UNAIDS is pushing against that. I have to say that we're not very clear on the stakes of the decision regarding timing. June seems to be very soon. So it seems on its face that later HLM would be better. But we generally tend to side with UNAIDS on those things. So I'm sure they have a good reason to prefer an earlier date. We also know that I don't know if the announcement has been official, that the multi-stakeholder task force has been nominated. I know we have at least one or two members on the call, and so we should be hearing more soon regarding the multi-stakeholder hearing. Also noting that in 2 weeks on our next regular call, we'll have an update from colleagues on the HIV HLM. So hopefully we'll have more certitude by then. Thank you all for your time. I hope to see you all in 2 weeks, and I want to thank again our presenters, including Nuria and Tess from MSF, and the team on our side. Thanks a lot, and we'll be in touch with information on those 2 webinars, one in French, one in English, that we're organizing next week around health financing.
Thank you. Bye.
Thanks, everyone. Bye-bye.